All right, people, settle down now. Sit down. We're going to wrap this here meeting up, talking about the things we're going to do on day 3 of this. All right, so what was yours? Registry. All right, so we're going to go registry. And so what we're going to do, we give each about 15, 20 minutes. You present your stuff, and then we have time for people in the audience to tell you why it's a horrible idea or a really good idea. Okay?
All right. Well, our group was tasked with natural history and registry, and we had a lot of good conversation outside, actually, because our first room was freezing cold. Anyways, I'm going to talk a little bit.
So we have the raw data here, as we talked about in our cognitive talk, and we've also done a summary. So if there's pieces from our group who were there, and we summarize, we don't bring up your point, feel free to
jump
in at the end. Thank you. Go ahead.
All right. So the goals really of the registry are, first of all, really to assess how treatments are being used today. What is standard of care therapy today? The second goal would be to predict and identify the frequency of comorbidities and predict risk factors for those comorbidities. The third goal was to identify research needs and direction. And then the fourth goal, and this is more from our pharma partners, is to help meet their regulatory requirements for industry. So we had thought that the registry would really be a joint project. It would be led by the Lennox-Gastaut Foundation, and there would be a board that would be elected to lead that. But it would be a joint partnership with families and caregivers, with providers, and with industry, but still would be owned and led by the LGS Foundation. The registry would involve both data from the EMR and patient and caregiver data that they would enter on an annual basis. So we would be able to measure things that also were important but not necessarily in the EMR. When we looked at who should be part of this or how we were going to identify patients, from a pediatric standpoint, that was pretty easy. We thought we could involve the PERC sites, and we would have quite a number of patients that would be followed through the PERC sites. We had a little bit of discussion as to how we were going to also identify sites to include adults, and I think we now have a number of adult people in the audience who could hopefully help us identify other centers that we could approach to identify adult patients with LGS as well. At each site, so the providers would need to opt in as this is something I'm interested in, and then at each site, patients would also have to opt in. So I want my data included in this, or I don't want my data included in this, and we're hoping that everybody would opt in to have their data included. In order to link the PERC or in order to link the EMR data to the patient entered data, everybody would be identified with a unique ID, and so the families and caregivers, every time they went in to enter data, would use that unique ID, and that would link that record into their EMR data. We are hoping to identify Zach as one of our leaders to sort out how we were actually going to mine the EMR data. I think most of us are using Epic, and we would have somebody like Zach help us pull in that data. So I think that the challenge would be if every provider had to enter data on every single patient. I don't think that's going to happen, and so I think we needed to have this as something that would be mined through the EMR. And we would identify specific data fields, including what types of seizures, the frequency of seizures, and we would need to encourage each of our clinician members to make sure that they actually entered accurate data on seizure frequency. It would pull in investigations, EEGs, including all of the EEGs over time, MRI, genetic studies, other studies. It would pull in information on anti-seizure therapies, including medications, dietary therapies, neuromodulation, et cetera, and as well would pull in data on hospitalizations and ER visits to kind of assess how frequently are seizure emergencies happening.
And in addition, and made a very good point, that functional adult data would be extremely important. A challenge is how to find that, such as employment services, seizure recording, use of wearables later on in life. And that was brought up as a point, too.
Mm-hmm. And then in addition, annually, we would ask families to go in and enter data about their loved ones. And also we would identify for specific comorbidities, sleep, development, behavior, things like that. We would involve KEDI and identify specific questionnaires that would be relevant so that we would have that information not only from the EMR, but a lot of that information is not in the EMR. So if we had sort of formal evaluations of sleep and behavior, et cetera, on an ongoing basis that were standardized. We also thought that it would be important to be able to add in new things as that became available. There was a comment about using wearables, particularly to assess seizure frequency in adults, where that may be less accurate because you don't have a parent who's necessarily watching the child all the time. And so if that became available, then we would want the flexibility of entering that into the database as well. We had talked a little bit about how this would be funded. And one idea that came from one of our industry partners was something that had been done similarly through the Spinal Muscular Atrophy Foundation, where industry actually partnered with the foundation. Industry was then able to get information on their drug only, and they only got it if they paid for that registry for the year. So if they funded for that year, they could pull data from their drug in an anonymized manner for the patients that were in the registry for that year. If they stopped funding, they didn't get any more data from them. And initially, the sort of carrot would be, what is the standard of care? How often are people actually using your medication? And so there was a number of people from industry, and they thought that that was something that their groups would be interested in. So the output really would be from a LGS foundation, from a clinician standpoint, what is currently being used, how effective are those therapies, how common are the specific comorbidities, potentially can we identify those, what are the risk factors, what treatments are being used for those. For families, the carrot there would be every year the families who participated in this would get an annual report on their child, and then they would be able to compare how their child is doing to the rest of the group collectively. And so families thought that that would be an important thing to get. And they would also be able to identify potentially research studies that they could be involved in, things like that. And then for industry, again, they would get information on an annual basis about patients on their particular medication, how frequently were they developing side effects, how well was it working.
And adding to that opt-in, opt-out function, families stated they could also choose whether to opt in to be contacted for further studies that may be available, not just industry, but both clinical studies as well as industry studies.
So some of the challenges that we ran into, obviously there's the importance of making sure that the data was kept private and secure. And so that data would be de-identified, and I think there are ways to actually appropriately de-identify that. We recognize it's a small community of rare diseases, but we could like shift birthdays and ages, and so patients would not be able to be clearly identified. Another concern arose was, what about the accuracy of data, making sure that when the data was entered, that it was entered accurately. And we thought that if we identified our PERC centers, we trust our PERC centers to know what is a specific seizure type. We trust our PERC centers to say there is, diffuse generalized slow spike wave or generalized paroxysmal fast activity or not. For families, if they were entering information on seizure types, We thought about potentially having videos that they could watch similar to what many of us watch for the Epilepsy Study Consortium when we do studies, so they could look at that, they could see what a tonic seizure looks like, they could see what an atypical absent seizure looked like, so they could actually identify what their loved one was having and make sure that that was as accurate as possible. Let me see. That was it for the challenges, I think. And then we had thought about the importance of, other carrots for people, for providers, for researchers. They would be able to come up with a question. We thought this would be really invaluable for some of our junior investigators, that they could, identify this very large population and say, hey, how common are sleep problems? How many people are being treated with melatonin versus trazodone, and how successful are that? So they could actually interrogate this large database and really kind of be energized to go forward and do their research. We thought it would be important, though, to have sort of a group of people through the LGS Foundation that would kind of be the oversight people, and if you wanted to have a specific research question, you would then take that to the LGS Foundation oversight group, and they would then allow access to that data. Importantly, any publications, any work that came out of this would need to acknowledge the LGS Foundation, would need to acknowledge all of the families and caregivers who participated and provided information, as well as the participating sites. What am I forgetting?
Perfect. Anything from our committee that we forgot? Yeah, in the back? Or questions? Questions to our committee? Because we obviously nailed it.
My question to you is that this sounds amazing. So exactly what are you going to have done in 2 years? Because that sounded huge. So like, really, what are we going to do in 2 years?
Well, I think that we can start small, and we can actually look at what is the standard of care. We can get our funding from our pharma partners to really start addressing that. Yeah, we could then make sure that we have built our data fields, and hopefully we could get that ready to kick off, I think, in a year.
And we thought that the task committee could be determined, and the initial goal of the task committee is to get input from these successful registries that we've heard about today: congenital heart disease. I think I can be here. Congenital heart disease, the SCN8A community, the SMA community, to sort of get a working task force. Could be done in a year. About POG was another example that was mentioned. What are the positive registries? How have they worked? What are their challenges that they have found? So that we're not reinventing the wheel. We could do this in a year because we could learn from the expertise that's already out there. That could then be compiled to be able to move forward. So there could be different task committees.
This is really cool, and I hope that it really, really works. My challenge to you would be to get enough money out of the gate to hire a data manager who does this professionally from the beginning. Because the problem that we get with big data sets is garbage in, garbage out. So you need to know that your fields are built properly. You need to know that there are regular data audits and that people are going back through and making sure that those data are really solid. And then having a statistician as the second body to be able to churn those numbers. And I would submit to it, the statistician and data manager should not be child neurologists or adult neurologists, but actual professionals in those fields.
Very good suggestion.
No, perfect, and that had been brought up, so that just echoes, I think, what was also discussed in the committee, so thank you. Any other questions? Yeah.
I just have a question. If you're doing caregiver entries, are you going to need an IRB approval?
I think it's going to be through the LGS Foundation, and so caregivers will opt in through the LGS Foundation.
Okay.
Yeah, just one comment. When it comes to the adults, as we know, a lot of the times it's really hard because sometimes families are not involved or even present on the picture any longer, and group homes have absolutely no clue a lot of the times what happened 1 year ago, let alone 30 years ago. So how are we going to address that?
I think that is a problem we're probably not going to be able to solve right away. And I would say that first of all, we want to make sure that the data we get in there are solid. And so if there is an adult who lives in a group home and nobody really has a clue what's going on with them, that's probably not the person we're going to want in the database, because we're not going to get very useful information. I think it would be important to recognize how many of those people are out there, right? Because that's a clear deficit in care, and we understand that. But if we're going to be looking at what are the predictors, how are they responding to medication, we need to have people in there that we can get solid data on. I don't know what you think about that.
Yeah, and hence the open in the future for things where we could get that kind of data, if there was wearables or if there was sampling that's often done for clinical research trials, to do sampling of time or something like that. So that would be a, if you will, an unfilled data point at this point until, there was some more information as to how to get good data. Yeah.
Maybe because they're not set up to do well, unfortunately, or they're being mismanaged. But that would be a deficit that would have us at
Absolutely.
An unmet need that the registry could address. Thank you all.
I would like to put in one more time advocating for a common note.
Yes.
Maybe not the whole thing, just very small portions of it. And then the patient taking the note and uploading it to the database. Because as much as I like George and the lawyers that work at my hospital, I'd rather not deal with them if I could avoid them. And so giving it to the patient is a much better way to share data, I think.
So I think Scott just volunteered to be the president of our...
Yes, he did.
I think I'm president of enough things.
One last question.
I want to say, I want to say on that regard, we're talking about HIPAA here, and I've heard you guys mention HIPAA you haven't said the word, but you mentioned you got it written, but I didn't hear it come out of yours. You mentioned securing information and make sure it's secure. We need to understand that HIPAA is twofold, and all we ever hear from the medical community is, hey, we got your stuff locked up tight, nobody else is going to get it. What we forget is that one of the P's in HIPAA is portability. And you already addressed a concern that, hey, I've got Epic, I can get that in there, but what if I'm not on Epic? What if I want to have my seizure information from Rob Moss and his seizure tracker app, and I'm a parent, I already have years of data that I can dump on you. I've got more data on seizure activity than most of you guys do in your research from one kid, right? And now you take a group of 100,000 parents who are running an app. Mm-hmm. We got to get that portability side in. I'm not sure how we do that. I haven't said much other than what I said the other day, but we've got to get the portability side of HIPAA in play, and this may be an opportunity for an organization to push that. Mm-hmm. It's not just about the privacy.
I agree, and I think that that's what I had mentioned in our, when we're putting data in, we need to have the flexibility. I think we have to start at some point, right? We need to be able to start with what we have and what's gettable and something that we can get off the ground quick. But I think at some point, seizure tracker, if there's wearables, all of that's going to be really important data that and so we want that flexibility to add that in. So you're absolutely right.
All right, thanks. Fabio's got something else to say, maybe, but I'm going to also make him walk up there to present his section so he can do both at the same time.
And I won't go up. Thank you, Scott. Yeah, as far as the portability, just an idea we've been thinking about, if the foundation could fund actually a NAP that could be used by the parents, that would automatically upload into the registry, we'll bypass the portability portion of it. And it's not that expensive these days to get a software engineer to come up with an app, maybe with the entries that are decided to be important that need to be there in the first place. I don't know what you think, because that's a great comment.
I would love to have a talk with you after the conference.
Okay. Okay, sounds good. Yeah.
Thank you, ladies. And team.
See how many doctors it takes to get that off. I know, I'll just take it a knife.
So we're the biomarkers group. I'm Dan Schrei.
Fabio.
Just Fabio.
Yes, Fabio. That's all you need to know.
So
Fabio, you know.
there's another one you probably haven't heard of him. So we had a really awesome discussion. It was super exciting. I don't want to stand in front of this, but as a lot of I think the talks throughout this meeting have gone, EEG was kind of front and center in our discussion as biomarkers because it does seem to be pretty relevant. I'm going to talk about our first aim, and then Fabio's going to take over for the second. One of our ideas was to focus on building an EEG-based LGS score. For those of you who are familiar with some of the recent developments in infantile spasms, the base score, the burden of amplitudes and epileptiform discharges score, came out about 5 years ago and has become more and more commonly used among pediatric hospitals and a way for us as EEG readers to look at a kid with spasms, look at their EEG, and give them a score 0, normal, to 5, markedly abnormal, to help guide us in terms of our treatment decisions. There's a lot of really good work being done to determine how correlated those scores are with how these kids do long term. We don't quite know that quite yet, but we do know that there's a very good agreement among all of us when we look at these EEGs and come up with these scores that if it's a 4 or a 5, if I think it's a 4 or 5, he thinks it's a 4 or 5, other people do too. And so, as was pointed out, some of the reliability of us just looking at a LGS EEG and determining how good or bad it is not great, and a score like this would help us to find a way that when we study this from a research perspective and ultimately use the EEG to help make treatment decisions beyond just seizure burden, that it would be a more reliable biomarker for us to do. So kind of modeling it after the base score, coming up with a group of experts to sit down and come up with potential elements of that score. Obviously, the two biomarkers we've talked about a lot, slow spike and wave and GPFA are going to be elements of that. How we are going to quantify those as clinicians, that is obviously yet to be determined. We'll kind of come up with what elements of the EEG should be included, and then through a Delphi process and a literature review in terms of what's relevant, and then we'll have a set of EEGs that have been confirmed to be LGS EEGs that we can all look at and see how well we do in terms of agreeing on scoring these EEGs. So I think that's the short version of AIM 1 is to kind of develop that score and to at least prove that when we do the scoring, we can agree with each other. The validating of the utility of the score in terms of the management of LGS is something else that he's going to touch on when he talks about his thing.
Awesome. And then when we sit down to look at the EEG biomarkers that we potentially will add to the list of biomarkers to be used in the score model and developed and assign different weights for different biomarkers, we plan to talk about other potential biomarkers outside of EEG, such as neuropsychological testing, genetics, clinical characteristics, and imaging abnormalities as well, to then use on AIM 2, where we can look retrospectively, linking up with the registry that was just presented, to see if we can categorize or stratify different subgroups within LGS using the trajectory over time. So it'll be AIM 2, and then AIM 3 will be to then use that knowledge from both the scoring model and the retrospective analysis of trajectories based on different biomarkers and put them to test in real life. So follow patients progressively and prospectively and see if the model can actually predict outcomes and can separate them in different groups and perhaps propose early management, early treatment, and see if that actually improves outcomes at the end. And then the other aim that's not going to be done by 2027, because the first two are the more important, would be to actually start looking and developing AI algorithms to find these EEG biomarkers instead of just relying on human eyes. And then we can probably start with GPFA and slow adrenaline spike wave, but also tackle the other biomarkers that will be set up by the Delphi process and included ultimately in the scarring base-like model ultimately. Anything else to add, Dan?
Yeah, there are a few kind of LGS databases out there that just even in our small group, we had a number of people who have been collecting this data locally at their institution. So I think a very easy first step is to kind of look at, go to the PERC LGS SIG, see how many people have these databases just already in process, combining that existing data, pulling raw EEG, as our kind of first pass, low-hanging fruit over the next couple of years to start seeing where the signals are, and then using those signals to build more of a multimodal signature to predict, among our high-risk spasms kids or kids with early life epilepsy, to predict like, oh yeah, this thing changed, 2 years before the LGS diagnosis. Maybe that's a critical thing we should be looking for. And then all of that will inform the design of a prospective study with more regular interval EEGs. When we're designing that study, and that's kind of the third aim we talked about, that's kind of, we want to be engaging the parent and caregiver groups to figure out like, oh, looking back, what things do you think were the signs that maybe your clinician didn't see, or maybe they did see and that's what prompted them to get that EEG that got you the diagnosis? Kind of developing those sorts of surveys that we can potentially use clinically on a regular basis in a high-risk kid to say, hey, every 3 months, these 10 questions, and if any of these red flags hit, you call us right away because we need to get you in. So engaging the parent and caregiver groups to really help us formulate a nice instrument like that, I think would be really critical for the development of the prospective look. And then also something we did in the base score, we're doing in the base score that we'd love to do with the LGS score is being able to quantitatively calculate it. And what that would allow us to do is if there's a center somewhere that maybe doesn't have an level 4 epilepsy center, doesn't have computational people, you can just upload the EEG, the algorithm processes it and gives you an LGS score. And so you can have that access even if you're in these more rural or under-resourced areas to have access to the same level of at least quantitative analysis of the EEG that you would at a center that had that capability.
That's it.
I think so.
Okay. Questions?
I got it.
I found Dr. Galinas' comment about drivers and passengers and biomarkers really interesting. And just wondering, did you think about stratifying as you go through this, mechanisms for identifying drivers and passengers and biomarkers? I don't know, it just sort of came up in my mind as I was thinking about it.
Sure. Yeah, I think that's going to be probably the main thrust of that kind of retrospective look where we pull that data, and that's what I meant with like trying to see where the signals are, right? So if we look, and retrospective data does have its inherent faults and its issues, but a lot of times even with those you could see, well, this thing actually performs pretty decently. It's not great. And then when you look at it prospectively, it does even better, sort of a thing. So I think that's going to be really illuminating. And I think coupled with what Zach Grinspan showed in his talk with kind of the onset of these different elements of LGS, seeing if we can pull some of that data retrospectively on a larger scale and seeing if those trends hold, looking at 400, 500 kids, I think will be helpful as well to kind of learn if those are really things we should be paying attention to. The trickier part's going to be looking at the people who didn't get LGS, right? And knowing were those people that would have never had LGS, or did they just get aggressively in early treatment so that they didn't get LGS? And because you don't want to be giving everybody an intervention if only half of them need it, and how do we know what's specific to LGS? And that's a really hard part of that equation. But that's why we're going to get a bunch of really smart people together to figure out how to do that.
Any others? Going once, twice? Sold. All right. Thanks, guys.
Thank you.
Okay, now it's Jim's turn. You can see Jim's plan over there. So this should be good.
Yours or no? No?
Scott, I would say my plan is just as visible as all theirs was to the audience, which is why we didn't waste our time on that. It was just, so we had an easier task, I think. We were just targeted with what was the best medicine to treat LGS, and we got that. So we're ready for 2 years from now. We'll announce it in 2 years. It's a secret until then. But ours was kind of figuring out best medical therapy. And we were charged to do like 2 specific aims that you could actually achieve. And our group took that to heart, I think, and tried to come up with achievable goals for what seemingly was a straightforward task. So I'll maybe start with the second one, and we'll go backwards. But our second one was to try and get the concept across that maybe we shouldn't just keep adding medicine after medicine after medicine as part of best medical therapy. And we had to draw a line in the sand somewhere. So we said, how about if we tried to implement an idea that if you have LGS, for most of your patients, nothing's 100%, you'll be on 3 medicines or less. And we thought maybe we could do that as a QI initiative through PERC. The advantage of doing it as a QI is QI initiatives don't require any kind of consent because they're QI. In most places, the state law covers QI without consent, but we could do it through PERC that way where they could actually just see if that even works. They could have their members, go through their charts, say, what does this look like, do QI in individual centers, and then say, oh, if we actually put this in and let our colleagues know, does that actually change things down the road? If we look at kind of where we have been historically, how many meds and folks were falling with that diagnosis, and then if we go forward a year, does it actually help? Then if it does, the next step is trying to figure out how we disseminate that in the wider world, which we didn't get to, but I guess that could be part of the 2027 meeting, if that works, is how do we get that out to everybody? So we thought that was an achievable one because that would actually improve care for folks from a medical standpoint if they were on a reasonable number of medicines. And then the first one, which was a bit trickier, was trying to figure out kind of best medical therapy, knowing we have kind of approved meds in LGS, so we at least know they work and where they work, and one historical med that we think works. And then we have meds that are not preferred, but unfortunately used a fair amount as well. So the goal was to say, how do we kind of build that into maybe an order set, an EPIC, and say, okay, if someone starts to put in, for example, on their LGS patient, that they're going to put them on regularly scheduled phenytoin, that kind of says, oh, you know what, that's not a preferred medicine. Do you really want to do that for maintenance medicine? And we have a preferred list that if they type in LGS, the list drops down with maybe formulations, so they know if it actually comes in a formulation their patient can actually take in, however they get their medicines. And we could even decide we want to build into that suggested doses or just leave it as preferred medicines and dose formulations, and then they can click and go through it, but with the idea that that might help guide people towards best medical therapy. So to do that goal, we didn't have someone better knowledge of medical records than myself. So how do you build order sets or something like that into EPIC? So we'd have to figure that out to get that built in. And then I think we could start just by rolling it out to folks that are in EPIC that are coding LGS. It could literally be all the folks. The trickier part may be how do we monitor that to see if that's doing anything? And that also would require someone with more EPIC knowledge than me to say, like, how do you actually, if you build it out, then monitor that going forward so that we know, is that actually changing behaviors between now and 2 years from now to where people are using what we call the preferred meds and not using the non-preferred meds. To achieve that one, we've got to find somebody. I'm not sure where our funding source is. We've got to find someone that knows medical record systems better than I do and see if they can help us figure that out. And then figure out if there's a funding that's also needed to do that. If it's just, no, you guys tell us what the order sets are, we can put them in, then that makes that a lot easier because we can do that and come up with preferred and non-preferred medicines. So the first step for probably to achieving that one is trying to get someone involved that understands how those are built in a widespread manner to medical record system. And we picked EPIC just because that's what most of the country's on, for good or bad, currently. So it gets us the most bang for our buck. So those were the aims that we chose to start with. So I'm open to questions, comments, criticisms, all the above.
All right, so I'll ask the question I asked while I was in there. So you pick an arbitrary number of 3 meds that you think is enough.
Well, I wouldn't say it's arbitrary, but we picked a number.
Well, okay.
It was a consensus, expert consensus.
Sure. All right, it was a consensus that 3 is the magic number, and you shouldn't have any more meds than that. So if your program works, then people who are on more than that will come down.
Some, not all of them. Some won't
How are you
keep
going to
it.
measure that that made a difference?
Because you're going to do a QI initiative. And that's how. So you'll track if they were able to come down to 3 and they stay there, then by default, the clinician is telling you, you know what, the family's happy, their seizures aren't worse, they're good being here. And the folks that bounce back up to 4 is like, oops, you know what, we do have some that are going to be on 4 and some that are going to probably be stuck at 5. Then at least we know kind of where that number is in the sand, so that if down the road, much like our CF centers did, that if we say, okay, that number above 3 is 18%, that if we have a center that's running 82%, we can say, you know what, this is the mean and you're like way over here, so what are you doing?
Could we look at, could we take a group of people that we want to call LGS experts that we think do a good job and like get an idea from the number of LGS patients they see, what is the average number of drugs that they have their kids on?
We could, but I think this is the next step, which is to say, this is where you have them on, but if we actually say, do they really need to be on all those? And do you want to look at that?
Well, I know, but I mean, I'm just thinking.
But that would be a start.
If we
You're right.
looked at this whole group, like these people we have here, and we go and we look, and we find out that actually our average number is 4.
Yep.
So, and I mean, maybe we're doing a crappy job, but 4 is what it is, and we're supposed to be the ones who know what we're doing. So then, do we set a goal and say that we think we ought to narrow it needs to be less, and so we ought to move towards 3, and then if we move towards 3, are we really doing any worse than we were when we were at an average of 4?
Probably not.
Yeah, I think not too. But.
Yeah, no, I'm fine with looking. We would just like to move this ahead as quickly as possible.
I like it, and I love the idea of doing it as a QI project. Just recognizing you do need an IRB prospectively in order to publish it, and it's going to be really important that
In the state of
information gets
Tennessee, you
published.
don't.
So,
State of Tennessee law, you don't have to have
okay,
an
but what
IRB.
about everybody else that's outside of the state of Tennessee?
I can't help it the other states are not enlightened. What can I say?
I do love that we design our ideas around not having to do research things.
Yeah,
How can I not have a DUA and not have an IRB?
Right. It does make them move quicker.
Any other questions before we wrap up this section? Okay, fantastic. So we've got, thank you, Jim.
That's right here, Scott.
So we've got, I think we have some outlines of some ideas, and they need a lot more outlining to it. And I think we really need to not drop the ball on this one. We want to probably set up some pretty regular engagement with these key people to see if we can move even one of these 3 concepts along. Would be great. We have 730 days until the next meeting. So we got to get going if we're going to do it. All right? Am I turning it back to you?
Thank you, Scott.